Good morning, everyone. Welcome to this one of my favorite session, which is heart disease and pregnancies. I work with an amazing team from Cornish Hospital, and most of them are here. Dr. Wani, Dr. Wael, Dr. Tariq, and Dr. Fatma, and our obstetric medicine consultant, Dr. Bashir, who is away on a trip during this conference. I would like to thank Dr. Fatma for helping us to prepare those presentations. And I'm going to present the second case. Just prior to presenting the second case, I will briefly present our team work and a summary, just an idea about where to go when you have a patient with heart disease during pregnancy, and if you have any raised question about their care before, during pregnancy, or after. Cornish Hospital is the largest maternity hospital in Abu Dhabi. There is an annual delivery rate around 6,000. There is an obstetric medicine cardiology clinic which has been established in 2007, managed by consultant of cardiologists, obstetrician, physician, and anesthetist. There are more than the database, which Dr. Fatma Farouk keeps really very updated, more than 800 which were referred to the clinic, 205 patients, around 205 patients with structural heart disease, and there were about 225 pregnancies. This is just an illustration of the type of heart disease that we see at the clinic, and you can see that there is congenital heart disease is an emerging cohort in those patients. There is also a subgroup of ischemic heart disease, valve disease, and cardiomyopathies. This is a slide which shows the maternal cardiac events is around 23.1%. and 12.8 for the patient in advanced country versus 36.3 in emerging countries. This is the rate of the events. And maybe the team can elaborate on this slide after the presentation. In 226 pregnancies, live births 200, there were a live birth of 210, neonatal death in 1. As it was explained, 3 sets of twins plus 1 triplet. Miscarriages happened in 10 cases, and termination were decided as a multidisciplinary decision in 10 cases. There is a large, a sizable portion of our cases which under the cardiomyopathy category. And some of the cases we manage with a variable clinical presentation of hypertrophic cardiomyopathy, which is the case that I'm going to present. We were discussing that this is, Dr. Salima Wani actually was very interested to show you this slide, which was in a 2019 paper from the AHA about cardiovascular consideration in caring for pregnant patients. And it really emphasized on the multidisciplinary approach in looking after those patients. We were discussing with Dr. Tariq just a few minutes ago that what's multidisciplinary? It's not only a group of people who will meet in a room and discuss the patient. It's actually speaking the same language, and most importantly is really is preparing the patient for the stress of the anesthesia or the anesthetist consideration during delivery and after delivery if needed, with minimal hemodynamic sequelae and minimal hemodynamic complication. Ideally, it's a preconception counseling, which is rarely we come across, but it's during pregnancy evaluation, diagnosis, revisiting the diagnosis, and looking for any hemodynamic sequelae or complication that happen. And then planning the delivery and keeping everyone in the team on board with the plan and explaining the rationale for each decision. This is a very challenging case that we've come across just recently. 30 years old, UAE national, non-congruous marriages, and she's a primigravida. She had a spontaneous conception. And this is important because you will have some background about her genetic diagnosis. She was booked as 6 weeks. Actually, I saw her around, I think, eight weeks or 9. She missed a couple of appointments. Her BMI is 21. She was quite a petite female, and with a weight around 45 to 50. She was diagnosed in 2013 after the sudden cardiac death of her brother at the age of 25. Her mother is also diagnosed with hypertrophic cardiomyopathy. She has 8 siblings who have not been screened for the hypertrophic cardiomyopathy. She had initial workup in 2013 in UK with a positive. She was genotyped and she was found positive for homozygous variant, gene mutation variant. Her mother also positive, and her children did not undergo any genetic testing at that time. She had an initial follow-up at the Zaid Military Hospital, multiple hospitals. She actually visited at least 3 cardiology departments prior to our clinic, and she seek consultation and counseling in at least 7 cardiology consultants from different hospitals and facilities. There was ongoing recommendation for an ICD as a primary prevention, but the patient refused. Her cardiac MRI had LGE, which was not very typical of her finding, of her diagnosis. I have to say, I've seen many hypertrophic cardiomyopathy. Her presentation was non-obstructive hypertrophic cardiomyopathy, minimal, I wouldn't say minimal, I would say around 15 to 17 maximum wall thickness, non-obstructive. She had a reduced ejection fraction. This is an ejection fraction prior to pregnancy. During pregnancy, that evolved and worsened systolic function. She had the diastolic dysfunction, and she has some element of pericardial effusion. Her past medical history has unprovoked syncope. No arrhythmias were found, and she was also considered as with diastolic heart failure. We have to recall that diastolic dysfunction is one of the earliest finding in hypertrophic cardiomyopathy as an echocardiography if you don't find all the features of the HCM. She was in sinus rhythm. She had a second visit to the clinic at 12 weeks, was commenced on bisoprolol, and third visit 15 weeks. She was counseled for ICD, refused. At 17 weeks, during the counseling, I told her that during your second trimester, around 24 weeks, you will start to have some symptoms, most likely will be symptomatic heart failure. But to my, I wouldn't say to my surprise, because she was atypical patient to start with, her heart failure symptoms were actually observed at 17 weeks. She was commenced on diuretics and was seen very regularly. Her ejection fraction on that echocardiogram was around 35, and she had elevated cardiac markers. This is just a log of the pro-BNP from the 11th week. As you see, it's 1,900, gradually increased to 2,917 week when I saw her, then increased gradually up to 3,423 weeks. And it reached the peak at 7,800 just before our further discussion and meeting with the team. I had to admit her electively around 19 weeks to commence intravenous diuretics and to re-counsel her about her condition, about the possible adverse outcome, and to revisit ICD, again with the electrophysiology team. She was admitted. She was noted to have a reduced systolic function with moderate pericardial effusion. Clinically, she was not in tamponade. Pericardial effusion raised a couple of questions. Pericardial effusion can be observed and seen in normal pregnancies, usually mild to moderate, no hemodynamic sequelae, and resolved after delivery. We looked actually it raised the question about a genetically based or the diagnosis of hypertrophic cardiomyopathy, and we were looking for could this be an infiltrative process? So I sent for blood work for protein electrophoresis, any diagnosis of infiltrative process like amyloidosis or any other etiologies. I sent for her whole exome sequencing to revisit and confirm the diagnosis of hypertrophic cardiomyopathy. There was a gradual increase in her diuretics. The other concern that we were challenged with her personality, because she was quite resistant to any changes in her medication, and she was quite concerned about the fetal status and the fetal outcome. So she had regular follow-up. We actually insisted to see her on weekly basis, a visit to my clinic, and then a visit to the high-risk pregnancy. We monitored her clinically with biomarkers, medication, and there was a very close monitor for her fetal scan. She was admitted at 26 weeks. She presented, and as Dr. Dima has pointed, it's also a clinically triggered decision. We saw her closely, myself, Dr. Salima Wani, Dr. Fatma, and we did observe there was a significant decline in her clinical status. She was dusky, kind of cyanosed, and was not doing well. Her symptoms, she was pacing her daily activities with her limited ability. So we admitted her at 26 weeks with worsening symptoms, rising BNP, and we increased her bisoprolol, and we commenced her on IV. We switched her diuretics to IV diuretics. And during that time, you have to also be aware that there was ongoing family meetings with the parents, with the husband, and with the family. It was a challenging family, at least to myself and to the team. But they were updated. They were very well informed. They challenged some of our decision, but patient safety was the goal here. And they were fully explained about all the possible adverse outcome and the possibilities. So intrauterine growth retardation, fetal loss, acute decompensated heart failure, intractable arrhythmias, stroke, they were all discussed with the family. And at one point, we actually brought up which is, I rarely bring that in my discussion in those cases, not because it doesn't happen, it can happen, but usually they tolerate pregnancy well. But this patient was atypical hypertrophic cardiomyopathy who had an early onset heart failure and persistence of heart failure symptoms and worsening. So we discussed actually the possibility of adverse outcome, including death. We also explained the backup plan of transferring her to an advanced heart failure transplant center if she deteriorates, the need for a cardiac ICU admission, either before delivery, after delivery, and all that has been explained to the parents and to the patient. She had a very close fetal medicine follow-up and discussion also with the fetal medicine consultant. She showed stage 3 IUGR, and there was a very close monitor of her measurements. It was a combined decision between the cardiology, obstetric, and anesthesia, and we decided that that was the time to proceed with delivery with a lower C-section at 27 plus 4 days under GA, and that because of some medication related to anticoagulation timing and the the concern that we had about the patient clinical status. Estimated blood loss, which is very important in those cases, in cardiac cases, as Dr. Tariq and Dr. Wani will explain, around 300 ml. After that, she was admitted for cardiac ICU for monitor after delivery. She was discharged in a stable condition. I saw her in follow-up. She still have persistent elevated BNP. She's still refusing ICD, and she will be seen in follow-up. Her baby has reached 580 at delivery, and I think very slowly growing in the NICU. Thank you.